In this module, we will discuss what makes a radiation epidemiology study reliable. The one thing that sets radiation studies apart from other studies is exposure assessment, the ability to determine the amount of radiation received by individuals in years past. Measures of radiation exposure on individuals are recorded, kept for decades, and can be used today to accurately estimate the amount of radiation energy absorbed by organs or tissues, the absorbed dose. Radiation epidemiology has become very sophisticated, more so than for any other environmental or worker hazard. Dose-response relationships can be evaluated, and reasonable estimates of possible low-dose effects can be made, although there's certainly more to be done. The key to good radiation epidemiology is good dosimetry. Without good dosimetry, radiation studies and their findings are unreliable and may be flawed. Sample or study size is important because it must be large enough to detect the effect you're looking for, as well as to minimize the impact or chance of random variation. This is called statistical power, or the ability to detect an effect had there been one. Publication bias occurs when journals are more likely to publish positive findings, or when investigators are more likely to write up and submit for publication their positive but not their negative findings. This bias can influence causal judgments because both sides of the story have not been told. There are, in fact, over 30 types of biases that can lead to incorrect results in epidemiologic studies. They can be put into two broad categories: information bias and selection bias. Selection bias, for example, occurs when subjects are enrolled for studies in different ways. Information bias occurs when data on exposure or outcome are obtained differently among study subjects. Information bias occurs when there are systematic differences in the information obtained. Recall bias in case control studies is a classic example. It occurs when the cases with a disease are more motivated to provide full exposure information and therefore provide different, more complete exposure histories than controls without the disease, who do not have a similar motivation and thus are more likely to underreport their exposure. Comparable information on exposure and outcome must be obtained, regardless of the amount of radiation dose received. Exposed and non-exposed groups must be treated equally. Special screening of only the exposed result in bias. Longer follow-up for disease detection based on exposure status would lead to bias. It's called follow-up bias. And then there is selection bias. Selection bias occurs when there is selective inclusion or exclusion of subjects in relation to exposure or outcome. The healthy worker effect is an example of a selection bias that occurs frequently in occupational studies. Employment selects able-bodied individuals who are relatively free of serious infirmities, and their mortality experience is generally more favorable than non-working groups. Comparisons with general population, which includes persons who are ill and unable to work, can be misleading, and internal comparisons between exposed and non-exposed workers in the same industry are to be preferred. Selection bias means including or excluding subjects based on exposure characteristics or on outcome. Selection bias distorts study findings and can lead to incorrect interpretations. Confounding factors are those other than radiation that could distort results if related to exposure status. Every attempt to minimize potential confounding factors should be made, such as sex, age, socioeconomic status, lifestyle variables such as smoking and alcohol consumption, and medical disease risk factors. Socioeconomic status, such as education level, is sometimes used as a crude surrogate for lifestyle variables that are frequently not available, especially tobacco use. The inability to address important confounding factors tempers any conclusions that can be made from a study. Why are these issues so important? They are of great concern when you're trying to estimate risks at very low radiation levels. All these sources of error, the biases, the confounding factors, and poor dosimetry, have a much greater influence when you're trying to detect a small increase in risk, say of 0.5% after a low-dose exposure, as opposed to increases of 20 or 30% after a higher dose exposure. For example, the predicted theoretical lifetime increase in cancer incidence after an acute exposure of 100 milligray is 1%. To put this in perspective, if 100 persons were exposed acutely to 100 milligray, one cancer occurrence would be predicted, whereas 42 incident cancers would be anticipated from all other causes, and 57 persons would not develop cancer at all. For lower doses, the epidemiologic challenges are even greater. For example, the predicted theoretical lifetime increase in cancer after an acute exposure of 10 milligray is 0.1%. To put this in perspective again, if 1,000 persons were exposed acutely to 10 milligray, one cancer would be predicted to occur, whereas 420 cancers would be anticipated from all other causes. A slight bias or influence of confounding factors could easily distort risk estimates at such low doses because the number of excess cancers is predicted to be so small compared with the background normal occurrence. But more importantly, it would be impossible or nearly impossible to detect convincingly or consistently such a small increase. Epidemiologically, it's difficult to detect low-dose effects where these biases, confounders, and dosimetry errors have much more influence at low doses than at high doses. Just to emphasize, for radiation epidemiology, dosimetry is the key. Since the beginning of the nuclear age, individual monitoring devices such as film badges were used in the United States. Individual records exist as early as the 1940s for workers at nuclear facilities, medical facilities, military facilities, and personnel involved with above-ground weapons testing, and other professions such as industrial radiographers. So, conducting occupational studies in the United States is a powerful and accurate way to evaluate potential risks from radiation exposures. The populations are well defined, and many individuals have radiation exposure measurements based on personal monitoring devices. Such rather exquisite dose records facilitate dose-response analyses and risk assessment. Dosimetry is key to good epidemiology. If you read a journal article and there is no mention whatsoever about radiation doses and it's claiming really high radiation risk, you should discount it. I'll provide a few examples later where investigators provide no or extremely poor information on radiation dose, yet claim evidence of low-dose radiation effects. Such studies occur not infrequently and are a problem if you can't separate the good from the flawed and unreliable. Let's talk now about two of the reliable studies, those of the Japanese atomic bomb survivors and of patients with tuberculosis who were monitored for years with chest fluoroscopic X-ray examinations. The primary basis for our standards and a lot of our understanding of radiation effects comes from the Japanese atomic bomb survivor study. These were the nuclear detonations that ended World War II in 1945 in Hiroshima and Nagasaki. About 2 years afterwards, President Harry Truman recommended that we study, along with Japanese colleagues, the survivors of the atomic bombings so we could learn about radiation effects on people. The Atomic Bomb Casualty Commission, and later renamed the Radiation Effects Research Foundation, was formed to study the population of survivors. And we, the United States, have maintained a continued partnership with the Japanese government and scientists for 70 years. A fundamental basis for a reliable study is having good dosimetry for a dose gradient. Here we see a dose-response curve showing excess relative risk for gray. At higher levels of radiation, such as half a gray and above, the dose response is statistically meaningful and there is clear evidence of radiation effects on people. Note that most studies involving radiation epidemiology have focused on higher doses and dose levels than a typical person would be exposed to today. How do we estimate risk or probability of disease at low radiation levels, especially when radiation dosimetry is limited? You can fit data with a straight line or a curve, and even consider whether a threshold exists or not. Which fit method is correct is currently debatable. Here lies the problem of providing reasonable estimates of risk at the low doses you and I are exposed to every day from medical examinations or treatments, natural or enhanced background radiation, breathing radon, frequent flying, or perhaps your work. And it's really hard to get a good handle on risk at these levels of low dose, where epidemiology is unable to provide a clear answer. Yet, regulators need to provide guidelines and manage such exposures. So any improvements in the estimates of risk at low doses, applying new technologies with much larger studies, are important, as well as considering knowledge gained from cellular, tissue, and animal experiments. The atomic bomb survivor study is a remarkable investigation. It has become the main source of information that regulators and radiation risk managers use for setting standards and guidelines. Nonetheless, and as to be discussed, it's not without limitations. Why is it reliable? The population study is exceptionally well defined. There's hardly anyone missing in the population as defined. It was based on a population census taken in 1950, where people recorded whether they were in Hiroshima or Nagasaki when the bombs were dropped. The dose estimates are exquisite. They rely upon estimates of bomb yields and heights of detonation and survivor memories as to their physical location when the flash of the A-bomb was experienced. But even today, and after 70 years, investigators continue to reassess and refine the individual estimates. The follow-up for mortality is nearly perfect because of the Japanese family registration system, the Koseki system. You can learn whether people are alive or dead or immigrated and their cause of death. As mentioned earlier, it's important to have as complete a follow-up as possible for everyone, the exposed and the non-exposed. You need to have complete ascertainment or determination of outcome. You also need to analyze the data properly. The analysis for the bomb survivors is state-of-the-art. In fact, the statisticians at the Radiation Effects Research Foundation developed the software that most radiation epidemiologists use today. How about interpretation for this study? It's always balanced. But if you disagree with the analyses or the interpretation, the data are available to you, and you can reanalyze and make your own interpretations. The Department of Energy has a similar repository of DOE worker studies called CEDAR, the Comprehensive Epidemiologic Data Resource. Although the study of atomic bomb survivors is a standard for excellence, it's not without limitations. One of the biggest limitations is that the exposure is acute or brief. We're not exposed acutely to radiation from an atomic bomb. We're exposed gradually over time. So, is this type of exposure really representative of our exposures that we receive today? Also, is a 1945 Asian population representative or generalizable to healthy Americans or astronauts today? Relative to some ongoing worker studies, which range from 400,000 to 1 million workers, the A-bomb study size is somewhat small. There are only 86,000 survivors with estimates of radiation dose. And when you split them into subgroup analyses, there's a lot of imprecision and statistical variation. For example, there are only 55,000 adults. And there is concern that inferences are based on combining all cancers and all ages in both sexes, where there is no biological rationale for doing so. Although this is the gold standard, an important limitation is the potential effect of confounders such as cigarette smoking. It's challenging to control for smoking when you don't have information on smoking until many years later, and not on everyone. The tuberculosis X-ray fluoroscopy study is another reliable investigation. It dealt with low-dose exposures received several times a month for 3 to 5 years from X-ray fluoroscopic exams to monitor lung collapse therapy. The low-dose exposures occurred so frequently over such a long time that the cumulated dose was high. There are 2 such studies, one in Massachusetts and the other in Canada. Full disclosure, the Massachusetts study started as my doctoral thesis in the early 1970s. It dealt with monitoring lung collapse therapy for tuberculosis in the 1930s to the 1950s. Patients would receive chest fluoroscopies every 2 weeks to monitor the extent of their lung collapse and to determine how much air should be re-injected into the pleural cavity. This treatment was welcomed by the patients because it allowed them to go home and leave the sanatoria. Without such therapy, patients remained in the sanatorium and treated with bed rest. Most were young, in the prime of life, and now could go home and be with their family and friends. The downside was that they had to return to the TB hospital every few weeks and receive a fluoroscopic examination of their chest each time. A fluoroscopy is, in a sense, a motion picture X-ray, and the machine would stay on for 10 to 15 seconds. Thus, the radiation received from each examination was not inconsequential. Some of the men and women developed skin cancer because the exposure from the repeated exams were so high. We were looking for the extent that young women develop breast cancer later in life. In this Massachusetts study, there was clear evidence for a radiation effect, and there was a dose gradient. The more fluoroscopies for lung collapse therapy, the higher the risk for breast cancer. Risk was concentrated among the young women. The women over the age of 40 had hardly any risk at all. The Canadian TB study had similar results. Thus, the TB studies did not stand alone and were consistent with each other, as well as with other investigations in other countries. When you're interpreting epidemiology and making judgments, one of the first questions to ask is whether findings of multiple studies are consistent with each other. Here, the atomic bomb survivor data showed the same pattern of response. Similarly, women treated with radiation for acute postpartum mastitis to reduce the pain of inflammation after childbirth showed the same dose-response pattern. So these studies fit together and provide a picture of risk that can be further refined in pooled analyses to obtain even better inferences. Such studies provided guidance as to balancing the potential risks from mammographic screening of asymptomatic women with the benefits of early detection and survival improvement. Radiation epidemiology was also influential in changing the way patients with breast cancer are treated because it demonstrated that scatter radiation during radiotherapy for the treatment of a primary breast cancer increased the risk of developing a new cancer in the contralateral or opposite breast. One of the interesting things about the TB studies was that women received fractionated exposure over a period of years, whereas the atomic bomb survivors and the mastitis patients received acute exposures, high doses in a short time. But all were consistent with a straight-line response. Most circumstances are not like this, but the breast risk for exposure to young women is particularly unique. The other thing is, and it's consistent with the Canadian study, we also looked at lung cancer. The lung doses were large, yet there was no excess lung cancer risk, consistent with studies of young women who received monitoring for scoliosis with high numbers of spinal x-rays. Breast, but not lung cancer excesses were found. This, then, indicated to many of us that tissues don't respond the same way to fractionation. Doses received gradually over time. Radiation causes lung cancer. There's no question about that. But whether it's caused at a high level when received gradually over time remains a question to be answered. Another point when looking at epidemiologic studies, be cautious when generalizing. The same TB radiation studies that found breast cancer to be elevated are the same ones that found lung cancer not to be elevated. The breast cancer results are accepted and results used in guidance. The lung cancer results have gained little traction to date in modifying protection guidance. These differences suggest that fractionated radiation has a lesser effect on lung cancer than acute exposures. New studies are ongoing to confirm these observations and whether radiation-induced lung cancer should be considered, so importantly, in risk projections for astronauts going to Mars, and whether the risk projections differ between men and women. Again, radiation epidemiology has implications today in many areas where judgments and decisions need to be made. We mentioned pooled analyses in Module 3, Epidemiologic Studies, a general overview. And there have been several really good ones, such as underground miners exposed to radon who developed lung cancer, and of children who developed thyroid cancer after exposures to radiation. There's been a similar pooled analysis for breast cancer. In all these studies, we obtained the original data from each investigator and then reanalyzed these original data together, parameterizing the factors in the same way based on follow-up, age, sex, and dose. A pooled analysis is somewhat more powerful and of higher quality than a meta-analysis. With a meta-analysis, you have to deal with what's published in the literature. With a pooled analysis, you can call your own shots. That is, analyze each study in the same manner using the same categories. So why is the TB study so reliable? The population is very well defined. We had access to all the records in Massachusetts from all the tuberculosis sanatoria. And we focused on the children and teenagers, but also included all adults. We had complete medical records and manually counted all the fluoroscopies associated with lung collapse treatment. We spent months in the sanatoria doing so. We personally interviewed the patients and the physicians, learning about the techniques used for the fluoroscopic examinations. We even serendipitously discovered an original fluoroscope from the 1920s that had never been used. With that, we reconstructed the dosimetry based on the exposure conditions that would have been present in the 1920s and the 1930s, and worked with the Food and Drug Administration's Radiological Laboratory in Massachusetts and the Oak Ridge National Laboratory in Tennessee in estimating the organ doses in an exquisite manner. We had near perfect follow-up. Massachusetts has unique resources called town books. Every year, everyone living in a town is listed. Father, mother, children, everyone. These town books were remarkable for studying young women where we had only their maiden names to start with. Further, using local resources, spending weeks in the archives of the State Department of Vital Statistics, and then linking with the National Death Index and other sources of mortality, such as the Social Security Death Index, resulted in only a few patients who were lost to follow-up. The outcome determinations, such as cause of death, were similarly complete for the same reasons. The analysis was pretty sophisticated. One of the leading statisticians at the Atomic Bomb Casualty Commission analyzed the data for us. So we're using state-of-the-art analyses. And finally, the study results are consistent with all published dependable and reliable studies. Accordingly, this study has been considered when making radiation protection guidelines and policy decisions.